This is a great course. I'm really delighted to be here. So thank you for the invitation. And we left this, or Fred and Jamie left this for last, and I think it's appropriate actually. I'm glad that it was last. I think it's an appropriate footnote, because probably the first thing to say is that the use of medication in autism should be thought of that in that way as a footnote, albeit it can be a very important footnote, but a footnote nonetheless. And you've covered some of the more important issues about diagnosis, about assessment, and about treatment without medication. I'll talk a little bit about non-medication treatments, but mostly today we're going to be talking about what the role of medication is or should be in autism. So let us get started. So the way I've divided this talk is into these 5 parts, 4 of which we'll include in the video, and then when we turn off the camera, if we have time, I have a couple of video examples. But the 4 things are some general considerations about medication, what they are, how we use them in autism. The second part is lessons learned, especially about things that have not worked so well, things we should be avoiding, but still important lessons to have been learned from those experiences. The bulk of the talk today is going to be on the third part, about these ongoing efforts, things that can be targeted with medication and what the evidence base is for that. What have we learned systematically about how best to use medication in children and adolescents with autism? And finally, very briefly, I'll play the role of a reader into the future and try to look into my crystal ball and try to make some predictions with you all about where I think medication might be going in the years to come. Again, in the last couple of minutes after we turn off the video, I have a couple of video examples of actual kids. So let's get started with some general considerations. Three brief points to get the conversation started. One about prevalence, and the second one about cost, just to put things into context. So 3 things that we can say is that medication is widespread. Even though I started by saying that it's a footnote, we know from a number of surveys and from epidemiology that medications are used very widely in kids with autism. Many different medications have been tried. The history here is somewhat checkered. Some things have been very helpful. Many things have not helped at all. And we know that psychotropic medications are costly. They cost a lot of money, and they can be a not insignificant part of the care for autism. So to put the prevalence into context, these are 3 select studies out of many that have been done, showing very simply what percentage of kids and adolescents with autism were treated with some psychotropic medication, any psychotropic medication. And these 3 examples, you see a study done in Virginia where 70% of kids were on some psychotropic medication, 52% in Minnesota, and in a very large nationwide Medicaid study, 56%. So roughly about 2/3 of kids at any given time are on some kind of psychotropic medication. Put that in contrast with the footnote comment that I've made at the start. Now, this is a snapshot of the United States. If we look around the world, and this is just one example, this is from Spain, from the Basque region of Spain, that happens to have a very good birth throughout life, cradle to grave system of treatment for autism. And in this region, where there are lots of interventions, including psychosocial interventions, home-based interventions, appropriate housing, appropriate medical care free of cost for everyone, we know from this rarefied and very specialized setting in the world that for them, over the last 10 years, they have had virtually the same rate of medication use, which is 30%. And it hasn't changed at all across many different medications tried. It's been a remarkably steady rate. So I don't want to read too much into this, but the point to be made is that the more systematic approaches that we have for approaching individuals with autism, the more interventions that we have, sometimes the less reliance that we need to have on medication. And we see across the United States a very disparate rate of medication use, and yet here, as in this one example, we see a highly consistent rate over time. Let me go back to the United States and give you another example of some of the things going on in the United States. And to put it into context, this is, I think, the only cartoon that I have, but Hippocrates, we know, the father of medicine, Andronicus, the father of dentistry, and then, of course, we have Phenilius, the father of upward spiral of healthcare costs. And it's, there's a point here. If you look at what has happened with medication costs and with psychiatric costs in the United States, again, this is just a snapshot of what happened in the late 90s. We don't have much reason to suspect that this has changed significantly. What you see here, don't worry about the smaller print here. The larger story is in these three color graphs. What we have in the green is what has happened to the use and the costs associated with inpatient psychiatric care. This is not just for kids with autism, this is for all kids with psychiatric conditions. And we see that in these 9 years, between these 4 years, between 1997 and 2001, all these costs have gone down by about 20%. 20% fewer kids in the hospital, 20% fewer payments, less. In the dark blue, we see a similar story for outpatient services. It turns out that there are fewer outpatient services, that the reimbursements are less and less. And what happens? In the light blue here, what has happened with medication. Medication costs during that same period of time have gone up. So we're spending more and more on medications. Medication use is very widespread. And sometimes there's a substitution of comprehensive care for the simple use of medication, which is certainly not what we're advocating here. It's more of a cautionary note to get us started. In the case of autism, we know less, but we know some. This is a study that looked at costs associated with autism in the beginning of the 2000s, between 2000 and 2004. And what we have here, this is a different coding. In the green, we have what has happened with autism, and we have in the three other colors 3 different psychiatric conditions. We have bipolar disorder in the blue, attention deficit disorder in the light blue, and other psychiatric conditions in the gray. What we see is that during these 4 years, costs associated with all of these conditions went up across the board. Things got more expensive, probably no surprise. More costs, whether it was for medication, for inpatient, for outpatient care. But we see that the condition that got the most dramatic increases in cost shift was autism. So in a very short period of time, costs associated with autism were much higher than for comparable conditions. So the steepest rise in cost was associated with autism. In this large insured population, the average, this is not necessarily applicable to the individual child, but it went from 40,000 per 10,000 individuals insured to 115,000. So regardless of the actual number, it more than doubled in a very short period of time. And medication, importantly, was one of the key drivers of these costs. Okay, so far with so much about some prevalence or some numbers to place the conversation in context. Now moving from cautionary notes, from what we don't want to advocate, to some more best practices, what we hope will happen and is increasingly happening in some places. We want, again, medication to be this footnote. We want medication, when used, to be only one part of a comprehensive treatment approach. Importantly, the medications that we use nowadays are mostly used for target symptoms, for problematic behaviors associated with autism, but not necessarily for the core symptoms, for the guts of the disorder, for the social impairment, for example. We don't, as of yet, have medications to treat that, but we have medications that can be very helpful for some of the associated target symptoms with autism, and if we can make an improvement on those, we can have a significant impact on the lives of children. Very importantly, medical aspects should not be overseen. And sometimes easy things, such as pain, let's say the pain from a tooth abscess, from a cavity, can be a big driver in some of the behavioral problems that then we're going to be trying to target with medications. So sometimes, rather than getting fancy and trying to stamp out behavioral problems with psychotropic medications, having a basic medical workup might be all that is necessary. Another thing not to be overseen in these kids is a pubertal transition, and when hormones and sexual urges and sexual development come online, that can really be a tremendous driver of some of the behavioral changes that then in some efforts we're trying to medicate away. going to these core versus target symptoms. So by now you should all be experts in knowing that the core symptoms of autism and related disorders fall into these three main categories. Impairment in social interaction certainly being the most important one, restrictive and repetitive behaviors and interests, and serious problems in communication and language. Unfortunately, we don't have any real medication to target any of those things. But what we do have are medications that can be quite helpful in aggression, in self-injury, seizures, and this is intended to represent the overshadowing of co-occurring psychopathology. The point here being that having autism does not immunize those children or adolescents, young adults from having other psychiatric pathology. In fact, there's a higher expression of other types of psychiatric disorders, anxiety, depression, whatnot, in children with autism. And sometimes there's this overshadowing effect where people think everything is a consequence or explained by autism. So this is a reminder that we should be paying attention to these underlying co-occurring psychiatric pathologies. Again, not all problems are always explained by autism. It is very easy to oversee even common psychopathology. Intellectual disability, for sure, mental retardation that can be present in 2/3, 3/4 of kids with autism. Depression and anxiety, these become particularly serious problems during adolescence, during young adulthood when some of these individuals, particularly the more higher functioning ones, might start seeing that there's something awry, that there's something amiss, that they can't quite connect the way they would like, and then as a consequence of that, they get depressed, they get anxious. Attention deficit disorder is common, and a frank psychosis can happen in autism, and it's very difficult sometimes to disentangle these serious pathologies. We do know, for example, that seizures are overrepresented as much as 4-fold more. Dr. Folkmar actually wrote one of the seminal papers showing that seizures are widely overrepresented in autism, and the same may be true for psychosis and other forms of serious pathology. Now the DSM, the Bible, if you will, that we use for psychiatric nomenclature has been very helpful, but it has introduced some sticky points. And one of them is this problem with parsimony, in that DSM really discourages making other diagnoses. So that if we have a child with serious problems with attention and hyperactivity, we're discouraged by DSM-4 rules to make a diagnosis of ADHD. Now, that may or may not be important, but in the context of talking about medication, it is relevant, because sometimes if we think that everything is explained on the basis of autism, we would not give some of these kids potentially beneficial treatments. Okay, so moving on to the second part. Autism has the unhappy news of probably being the condition, at least in psychiatry, in child psychiatry, for which the most weird and varied types of useless interventions have been applied. Most of the times by well-meaning people, but sometimes not. This is just a very select, brief representation of some of the things that have been tried. Irlen lenses, facilitated communication, psychoanalysis, psychocranial therapy, animal-assisted therapies, packing, le packing, something that is still applied and in vogue in France, where children are wrapped with wet towels, and while they're in this condition, they are talked about, they're unconscious, and the story just gets crazier. There are many things that really fall close to, or not close to, fall squarely in unethical and really unproven treatments. Antipsychotic treatments. Two of the probably more relevant recent ones that may ring some bells. One has to do with the whole controversy about autism and trying to use, about vaccination and autism, and about these efforts to use chelation, chemicals, medications to chelate, to bring down the allegedly abnormal levels of heavy metals, for example. These interventions can in themselves be quite dangerous, and there have been at least a couple of deaths associated with the use of these chelator treatments. Now, secretin I highlighted here because although it's a treatment that has been proven ineffective, and I won't go into all the details of what it is and so forth, just to say that it's been ineffective, but there's a couple of points to be learned from secretin. This is a screenshot from a study showing not just that one study or two studies or three studies were negative, but that 15 double-blind control studies had shown without the shadow of a doubt that this intervention didn't help as initially suggested. 15 studies. As you will see when I describe what works and what has been tested, we'd be lucky if we had 15 studies overall. And yet 15 studies were dedicated to this one intervention that proved to be a lost cause. So what are some of the things that we can learn from this? And again, Fred wrote a relevant editorial about this. It's very easy to go from a hopeful message, one child responded to secretin, to really running with it. And at that time, a decade ago, secretin really captured the imagination of the public. And in a very short period of time, during 4 years, there were 600 individuals who were randomized to receive secretin versus placebo. To this day, secretin remains the most extensively studied intervention pharmacologically in autism. This was a huge federal investment of dollars, and there was absolutely no evidence of efficacy. So all of this is a real downer, and this is really negative. And why am I telling you this story? Well, the silver lining in this story, and I think it's an important one, is that all of this was pushed really by consumer family advocate groups. Autism has really taken a lead in vocal, proactive parents and support groups who have really placed things on the map. And although this particular cause didn't yield the results that we would have hoped, these same groups are the ones that have placed autism in such a positive way in the public's opinion. It's why we have these kinds of courses. It's why we're on YouTube. It is why federal funding for autism has increased to the levels that it has. So I think that that's one of the good pieces of the secretin, otherwise sad story. Now, moving from that into some of what we do know. There have been major advances over the past decade, and at least partly really spurred by these advocacy efforts by families and involved others. Before 2000, the year 2000, there were very few studies done with autism, and the ones that we had were with very small samples, fewer than 100 children, which is really not much to say anything decisively. Some of the challenges have included that recruitment into studies is a very challenging proposition. It's very hard to find children and families who will agree to be enrolled in these studies. And the corollary of this is that most of these studies that I'll describe had to be multi-site efforts, many different sites coming together in order to identify and recruit sufficient number of children. Studies like these are extremely costly and time-consuming, and the federal funding is absolutely critical for them. NIMH, the National Institute of Mental Health, and NICHD, the National Institute for Child Health and Development, are two of the main funders of these large studies. And luckily for us, the evidence base is growing. There are certain things that we can say today about do's and do nots in the use of medication that are based not just on personal opinion, but on actual data. And that is all good news. So let me try to deconstruct that a little bit for us. The way that I'll do this is by talking about some of the key target symptoms that can be effectively targeted with medication. As I said, the core symptoms as of today cannot be really modified much with medication, but some of these other target symptoms can. The first one, and probably the one where we're doing the best, is irritability, aggression, self-injury, property destruction. All of these things that can make really impossible to live with a child with autism, because one thing is to be ignored, if you will, by your child, or not to have the kind of intense emotional contact that you would like with a child, and that is very painful. But if in addition to that your child is destroying the house and hitting you and kicking you and biting you, it takes the challenge into a whole other level. And medication can be actually quite helpful for that, as I'll describe. The other two target symptoms that I'll describe where we haven't done quite as well are hyperactivity and inattention and repetitive behaviors. So let's start with some of this aggression. The core treatments that we use for aggression are what we call atypical antipsychotics. Antipsychotics, And this may be very basic for some of you, but just so that we all are on the same page. Antipsychotics are medications that we have used since the 1960s for the treatment of a range of serious psychopathology, traditionally schizophrenia. The traditional antipsychotics all have effects on the dopamine synapse. And this is a cartoon of our friend the dopamine synapse, where we have a presynaptic cleft, a postsynaptic cleft, and dopamine is released into the synaptic space. And the key mechanism through which antipsychotics work is by blocking the attachment of these dopamine molecules to the dopamine receptor, and particularly a D2, a dopamine 2 type of receptor. That is the main mechanism of action for these medications. Now, we know that these traditional antipsychotics had been effective in small randomized controlled trials in autism, and that was good news in these small, fewer than 100 children cases. But there were some problems associated with them, and particularly this thing called tardive dyskinesia, which is a long-lasting, permanent side effect, a movement disorder, typically of movements around the mouth and the face, that can be permanent, cannot go away. Even though the incidence of that was relatively small, it wasn't something that we saw much, it was concerning in that it was an irreversible side effect. That was part of the reason why we have moved over the last decade almost completely to what are called atypical antipsychotics. Atypical antipsychotics also work on the dopamine system, but they have other effects. They also work on the serotonin system. And importantly, they have a much lower risk of these tardive dystonias and dyskinesias, and they seem to be quite promising in small samples and small case series of children with autism. Two more things about dopamine and the antipsychotics. This is a cartoon of the key brain pathways involved in dopamine transmission. So these are some of the places where these antipsychotic medications work. There are projections that go into the frontal cortex that have to do with some of the higher functioning activities of the brain, but they also go into some of these deeper structures of the brain, and some of this has to do with, has relevance to some of their side effect profile. For example, weight gain, appetite increase. Some are things that are handled in deeper brain structures in the hypothalamus and the thalamus. This is a cartoon very similar to the first one, showing, again, a dopamine synapse, and showing that these atypical antipsychotics not only work on dopamine, as we saw in the first cartoon, but they also have effects on the serotonergic transmission. So they are mixed agents that have effects on both dopamine and serotonin, and this may explain why they are more effective, they have fewer side effects, and so forth. Okay. There are a number of atypical antipsychotics. The most commonly used one, the one we know the best in autism, is risperidone. Risperidone is the first of this bunch, and it's really a great thing that here at Yale we were the primary site and the organizing site for the key study that proved the efficacy of risperidone in autism. And our colleague Larry Scahill was a principal investigator coordinating this very massive effort. 101 subjects, which doesn't sound like much, but this took a couple of years to recruit these subjects. The vast majority, consistent with what we know with autism, were boys. The age range was children and adolescents, ages 5 through 17, and this was a double-blind placebo-controlled study, meaning that neither the patient nor the investigators knew what the pill was that the children were receiving until after the study was completed. This RUP study, RUP, by the way, stands for Research Units in Pediatric Psychopharmacology, and this network, again coordinated by Larry Scahill here at Yale, consisted of 4 other sites: UCLA, Indiana University in Indianapolis, Ohio State University in Columbus, and the Kennedy Krieger Center in Baltimore. And through these 5 sites, we were able to accrue sufficient individuals to do this study. What are some of the key messages of the risperidone study? This is a snapshot of what happened at the end of the 8 weeks of the study. You see here the ratings every 2 weeks, and very clearly you see the separation between the group treated with risperidone, whose ratings go down, and the group on placebo, who stays very similar over time. If we want to give that some numbers to know, is this a little or is this a big difference, In this particular scale that was used, called the Aberrant Behavior Checklist, children with placebo, 52 of them, really didn't change much, 4 points fewer, not a real difference, compared to 15 points of decrease in those treated with risperidone. When we statistically analyze that, that comes out to be an effect size of 1.2. Effect sizes above 0.8 are considered to be large. There are relatively few, actually very few interventions in psychopharmacology that have effect sizes this big. So the take-home point is that risperidone was not only effective in autism to reduce these behaviors of aggression, impulsivity, and so forth, but that it was dramatically effective, making it one of the most useful medications that we have in our current armamentarium.
Could you describe like a subjective version of what that means? Like kids who acted out on their parents every day, only acted out once a week, or still that way. How big is a big effect?
Right. So the question is how to translate these kind of statistical numbers into real what happens with kids at home. The type of behaviors that were most commonly seen were hitting, aggression against self. Some of these, there was a wide variation. Some kids were constantly hitting themselves, were constantly hitting families. Some of them maybe 2 or 3 times a week, some maybe once a month. But the point is that wherever they started, they had a dramatic decrease by 50, 60%. In very few kids did these behaviors completely disappear. In some they did, but mostly there was a dramatic decrease. So if someone started with 10 times a week, let's say, having some episode like this, maybe by the end of the trial we're talking about 1 or 2 a week. Another way of quantifying this, and maybe related to your question, is this. This was another way of looking at the same data, but here rather than using that scale, the Aberrant Behavior Checklist, we're using this poor man's scale called the Clinical Impression Scale, which essentially is what you're asking. In my clinical impression as a clinician or as a parent, who is getting better? And here we see that about 80% of children treated with risperidone got better compared to only 10, 12% of those kids treated with placebo. And one way of thinking about this, of translating this into a number more usable with the patient that we're treating, with the individual child that we have, is this notion of number needed to treat, which again is a variation of what you're asking. A number needed to treat tells us that we would have to treat 2 children with this similar behavioral kind of problems before we saw one of them getting better related to the medication. So to give you a sense of scale, most medical interventions have an NNT, a number needed to treat, in the 10 to 50 range. We need to treat that many children before we see an improvement. Something that has an NNT of 2 is a really very, very successful intervention. So we're talking about medications that are really quite dramatically effective. The main thing for which risperidone was helpful was irritability, this aggression type of behaviors. But the Aberrant Behavior Checklist, this scale that I mentioned, taps into 5 different domains: social withdrawal, stereotypy or repetitive behaviors, hyperactivity, and problems with speech. And what we see here is that there's some difference, starting risperidone in the purple and risperidone at the end of treatment, both in the purple lines, and in the tan lines we have placebo at the beginning and at the end of the treatment. What we saw at the end of this trial was that certainly irritability was the main thing that improved, but there were also some changes in stereotypy. So some of these repetitive behaviors also got better, and some of the hyperactivity also got better. Not quite as dramatically as aggression, but the point is that there were some other benefits seen with the use of risperidone in these kids. Another important point is that some of these benefits were not short-lived. Even though the trial lasted only 8 weeks, represented here in the green and the red bars. In the green we have the placebo group, and in the red we have the risperidone group. And if you recall, that trial was only 8 weeks. But in a subsequent study that went out to 24 weeks, we saw that during open label extension, meaning that by now we knew who was getting the risperidone, there was no longer this deceit with the placebo, but that these benefits were sustained over 24 weeks. In fact, later on, when there was an effort to discontinue in a blinded way, again introducing a placebo to half of the kids and keeping half of them in risperidone, that particular study had to be stopped prematurely because virtually all of the kids who were assigned to placebo very quickly had a regression in their symptoms, and they needed to be placed back on risperidone. So we know that this medication is effective, that it is effective in a range of symptoms, and all of this is information particular for autism, which is unique. So what next? Well, one of the things, and this is really brand new information that was just published this month, again, Larry Scahill here and some of his colleagues have taken the lead in this, is that risperidone should not be used alone. And what they have done is experimentally looking at this. Can we complement a medication such as risperidone with psychosocial interventions, in this case with a structured parent training? In this case, they use a manualized intervention, 11 sessions, 12 sessions. There are a range of didactic materials that included videos, scripts, specific tasks that would be done with a child, reinforcement, positive reinforcement for doing things well, some functional communication skills, helping the child better identify needs and wants, and having behavioral rehearsal for problematic behaviors with extensive feedback and homework. In doing this, you won't be surprised to find out that in the combination group, here represented in the blue line, things went better than in the risperidone-only group. The difference is certainly not as dramatic as in the previous slide, but the point is that complementing behavioral interventions to medication gives the best of both worlds. In this case, again, we're comparing medication alone to medication and psychosocial intervention and seeing the added benefits of adding this intervention. The FDA, as you know, is involved in the marketing and the branding of medications and the safety of medications. And this is a partial list of the very few of the dozen or so medications that have been approved by the FDA for use in kids under the age of 18. This is a partial list, but you can see that most of these medications have been used. For example, methylphenidate or Ritalin has been approved for its use in attention deficit disorder. There's a range of antidepressants that have been approved for use in obsessive compulsive disorder, lithium in mania, some antipsychotics for Tourette's syndrome, haloperidol for explosiveness, imipramine for enuresis. And the list is no much longer than this. I do want to highlight that risperidone is now part of that list, and that through these studies, risperidone is now one of only a dozen or so medications that have the FDA blessing and approval to be used in a psychiatric condition of childhood. Most of the medications that we use in children with psychiatric conditions are used off-label, meaning that a physician can prescribe them even though the FDA has not quite approved them for that indication. But when we have these medications that do have that stamp of approval, it tells us that there has been this additional level of scrutiny of safety associated with the medication. So all of that is great. What is the bad news that I'm not telling you, or is it all good? Well, there's a little bit of bad news, and the main bad news has to do with this side effect, which is weight gain. Weight gain is the most important side effect associated with these medications. This is a study that was published recently, not relevant only to autism, but to a range of psychiatric disorders in children, where 270 children were followed over 3 months. And you see their mean increase in weight during this time frame. You see that 5 atypical antipsychotics here are all, four atypical antipsychotics are all associated with weight increase. Olanzapine has the highest weight increase, an average of 8 kilos in 3 months. So that's 1.5 kilos, 3 or 4 pounds per month. Quetiapine, another antipsychotic, and here risperidone, the one that we've been talking about, an average weight gain of close to 5 kilos over 3 months. So weight gain is the main problem that we have to fend with. This unremarkable line here is an untreated group, and this smaller graph here represents aripiprazole. Aripiprazole is another atypical antipsychotic that has recently been tried in autism. It is comparable to risperidone in its efficacy, and it seems to have somewhat lesser of impact on weight gain. You can imagine the problems associated with weight gain. These are the same data expressed slightly differently as percent of body weight increased. So you see weight increase that goes as much as 15%. In the case of Risperidone, a weight increase of 10% of weight increase over 3 months. And associated with that, you can imagine all the metabolic and physical problems that go with that. We are concerned about kids who continue to gain weight, what kind of metabolic problems they might have down the line, including things such as elevated cholesterol, triglycerides, diabetes, etc. Question?
How does that effect play out over further time?
Does it continue indefinitely? We don't really know, but we have a sense that it does plateau somewhere around 1 year. So these kids don't continue gaining indefinitely. But there is this very dramatic weight gain over the first 3 months. It starts to slow down during the first 6 months or so. But we don't know.
Do you know what the average is for, like, if you just took, like, you guessed for like a 2-year period, right, and plateaus, what's the average weight gain?
You know, it's a tricky question, particularly for kids, because remember that kids are also, in a normative way, gaining weight. So in some ways, the right question is not how much weight itself. We have fancier ways of measuring it that have to do with what are the growth charts that you will remember from when you went to your pediatrician. You know, you're growing at a steady rate, and the question here is who gets off of that curve through the effect of the medication. And there's a sizable proportion of those kids. My guesstimate would be that 20, 30, maybe 40% of kids gain weight in that significant weight. So not everybody, but a significant proportion. Okay, so I started with Risperidone because this is a medication we know the most about and the one that has the best track record for, and even now the FDA approval, as I mentioned. But there are 2 other classes of medications that have been tried. For inattention, hyperactivity, stimulants have been used. The most common stimulant, of course, is methylphenidate, aka Ritalin, and we know that there's a large body of data for the use of stimulants in attention deficit disorder, but there had only been anecdotal reports in autism. Could these medications work? Well, they might, but there were also similar reports that they could worsen problems such as stereotypies, repetitive behaviors. Many concerns that the medication could make these things worse. Could they worsen the irritability that I just talked about, the efforts that we have done to stamp out with things like Risperidone? And there were also some reports that these medications could increase social withdrawal and isolation. So over the last couple of years, we've had some data specific for autism. These medications all, by the way, act also on dopamine, but in a different pathway. This is a cartoon of the synapse, and if you recall, in the antipsychotics, they blocked the attachment of dopamine to the postsynaptic receptors. By contrast, these medications, the stimulants, what they do is push dopamine out into the synaptic cleft. So they increase the levels of dopamine, whether it is by inhibiting the reabsorption of dopamine into these presynaptic vesicles, whether it's by blocking the reuptake into the synapse. Through a range of mechanisms, they push dopamine out into the synapse, and we think that that's one of the ways through which they work. Now, leaving that basic science finding aside, or explanation aside, what do we know about how these medications work in kids? Once again, a multi-site effort, much the same network, the RUP network around the country. In this case, through a lot of efforts, 72 children were enrolled. Very hard to enroll. A lot of hesitation about using these medications in kids with autism, and a very very careful design in which there was a first week in which just a very teeny small test dose was given, and if those kids could tolerate it, then they went into a 4-week double-blind phase where they were given either a placebo, a sugar pill, or the stimulant methylphenidate, Ritalin, in 3 different doses, a low, a medium, and a high. It was an 8-week study, a 4-week double-blind study followed by an 8-week extension. And what is it that was found? Well, rather than just showing you what was found, let me compare that to what we know about the treatment of ADHD in kids without autism. The MTA, the I'm blanking on the multi-something. I'm blanking on what the MTA, it's one of these things that you use so much, multifaceted, multi-something treatment of ADHD. This is the largest study, the granddaddy of all ADHD studies. And I'm going to compare what we know from that Rolls-Royce study in kids without autism to what we know in autism. So the first thing is that most kids respond, whether they have autism or not. But we see that the response rate in the MTA in kids with without autism was close to 80%. Most kids respond and respond very dramatically to stimulants. Their inattention, their impulsivity gets better. The first observation is that in the case of autism, the response is not nearly as much. About 40%, 50% of kids responded. The second observation is that this is not accounted by placebo response, because the placebo response across these two groups was essentially identical. So the kids responded just as poorly to placebo. They didn't respond to placebo. When we try to quantify that, we see that methylphenidate, again Ritalin, used either in a low, in a medium, or a high dose, seems to have some efficacy for autism. All of these are effect sizes in the range of 0.3 to 0.5. Compare that to what we had talked about with autism, that with Risperidone, those effect sizes of 1.2 that were very dramatic. So these are subtle, these are small effect sizes compared to what we know in normally developing children. So in normally developing children, Ritalins and similar medications can have this really wow effect, something that we don't see in autism. The other thing that we saw in autism is that discontinuation was much more dramatic. We saw that in the MTA, it was a very small fraction of kids who discontinued treatment during the double-blind study. Just a couple of percentage, 2, 3, 4% of kids discontinued. In this trial with autism, about 15% of kids discontinued. So, in summary, these medications can be helpful for the targeting of inattention and impulsivity and irritability and attention, but not nearly as much as in normally developing kids, and there are more significant side effects. So these are in the so-so category. The third and last medication that has been extensively studied in autism is to target repetitive behaviors. Some of these interfering behaviors where a child will spend a lot of time doing the same activity over and over again to the exclusion of more socially adequate or appropriate activities. Now, there has been a lot of interest in the similarity between some of the repetitive behaviors in autism and obsessive compulsive disorder. And we know that there's a very strong evidence for the use of medications, antidepressant medications called SSRIs, selective serotonin reuptake inhibitors, in the treatment of OCD. And that was part of the rationale for trying these medications in autism. We also know that there is a lot of evidence, and old evidence going back to the 60s, that serotonin metabolism is abnormal in autism. And we have some preliminary evidence that these medications are helpful in adults with autism. We also know, as I had mentioned, that depression and anxiety, conditions that are targeted by these medications, happen more commonly in kids with autism, particularly higher functioning autism. So based on all of this, it seemed like a slam dunk that these medications would be very helpful in autism. Again, to bring us all to speed on what these medications are and how they work, this is a cartoon of a serotonergic neuron. And you see here the presynaptic neuron, the synaptic cleft, the postsynaptic membrane. And when serotonin is released, it typically applies or lands on a serotonin receptor. SSRIs, or serotonin reuptake inhibitors, block that. They block the reuptake of serotonin back into the presynaptic neuron, with a net effect that there's this accumulation or this excess of serotonin in the synaptic cleft. And that is the basic mechanism of how these medications work. Now, there's a range of these medications, the most common one, of course, being Prozac or fluoxetine. As I had mentioned, there was some preliminary evidence done here in the 1990s by our colleague Chris McDougall, who's now in Indiana University working with adults with autism, and showing that adults treated with this particular SSRI called fluvoxamine, which is a first-degree cousin of Prozac, they improved quite substantially in their repetitive behaviors. In the case of fluvoxamine, about half of these individuals improved compared to none of the adults with autism. Granted, these were small samples, 15 individuals in each group, but this seemed to be promising information. Based on this, a very large-scale study was done, and see how the sample size keeps on creeping up. We had seen that Risperidone study was 101 children. By now, 149 children in the same age range, 5 to 17, were treated in this double-blind, placebo-controlled way with fluvoxamine. This study, again, was a multi-site study. It was a different group of collaborators called the START network, which is a Center of Excellence in Autism, and some of the usual subjects, UCLA and Yale, but also some other colleagues at Dartmouth. The lead author of this study, Brian King, is at Dartmouth, Mount Sinai, and the University of North Carolina in Chapel Hill. Now, exciting as this map is, and exciting as the background was, the results were rather not so exciting. In fact, as you can see, there was no difference between the group treated with the antidepressant and that treated with placebo. There was really no difference. And this was through both this clinical global impression scale that I had mentioned before, or through a more nuanced way of measuring these symptoms, the Yale-Brown Obsessive Compulsive Scale. In any way that the study was looked at, these kids really didn't improve. And not only was this medication no better than placebo, but it was also very poorly tolerated. There was an increase in impulsivity and hyperactivity and insomnia and behavioral activation, a whole set of problems. So this study, published in one of the leading journals, and really a very important study, the importance of it was showing that this intervention didn't work, and that a widespread intervention was really not justified. And if we go back to the excess of use of medication, the excess of cost, now we have some information, some empirically derived information to tell us, well, maybe we shouldn't be using this kind of medication. It may be that, seductive as it sounded to link obsessive compulsive disorder and OCD, that may have been overstated. So that is what we know based on the medications that we have around. For the last 2 or 3 slides, I want to be a little bit of a psychic and try to think of where we hope things will go. Well, on the one hand, I think that we're going to continue making these very gradual, stepwise, slow interventions. There's a number of medications. This is just a select few of the medications that are being targeted for these range of symptoms that I mentioned. So for example, for irritability and aggression, there's a lot of interest in other atypical antipsychotics. We know that these medications are very helpful, but we know that they lead to weight gain and other problems. So these are 3 of the medications that are being looked at as possibilities that could have less weight gain, for example. So this is not a radically different new innovation. It's just trying to tweak an already useful intervention. For the case of hyperactivity and inattention, there wasn't really a whole lot to say for the methylphenidate. If you remember, the response was so-so. There were lots of side effects. So there's a lot of attention or interest in other compounds, including guanfacine and atomoxetine, which are medications that are widely used in ADHD, but that act through a different mechanism. They haven't been yet tested in autism, but there's interest in them. And for repetitive behaviors, there's a new medication, relatively new medication called riluzole, that has garnered a lot of attention. All of these are, again, the stepwise incremental steps that probably won't be game changers in how we think about the treatment of autism, but that they could continue providing some relief to children and families. But what are some of those game changers that I suspect we may be seeing? Well, one of them comes from the example of Fragile X syndrome. You may have heard Fragile X is a common form of mental retardation. It's in fact the most common form of inherited syndrome of mental retardation. And we know that it's associated with some specific facial features, an elongated face, narrowly set eyes, a flattened nose, and this very traditional appearance. We also know that the chromosomes of individuals with Fragile X have some select abnormalities, and that's why the syndrome is called Fragile X, because the X chromosome, when looked under a microscope, has this very typical break. And over the last couple of years, we've learned a lot about the machinery inside of this syndrome, which I won't go into right now. But what we do know is that if we take a a snapshot of what the neurons of individuals with Fragile X syndrome look like, we see here in this panel what a normal neural extension looks like with all these many spines, these connections between neurons, compared to what happens in Fragile X, where we have this smooth, sad-looking neural extension. We know that from visualizing these brains under the microscope. But over the last couple of years, we've learned a lot of what the underlying molecular genetics of that are, represented here in this cartoon. We know that there's this Fragile X protein that is produced in excess in Fragile X. And we know that some new chemical compounds in a family called mGlu-R5 antagonists, it's a mouthful, and that's not particularly relevant. But what is relevant is that these types of interventions are now being applied to mice that have a model very similar to Fragile X in mice. And these interventions, these chemical compounds that can not only prevent the development of Fragile X in mice, but they can even revert some of the early phases of the disorder. And this sounds a little bit like science fiction, but we are already starting, not we, but others are already starting what are called phase 1 and phase 2 trials of these compounds in humans, meaning that the very early trials that will eventually lead to the kind of larger trials that I described, where we're still seeing the feasibility, the safety of these compounds in humans, but it may not be too far off that over the next decade or two, and when you are up here giving this lecture, it may be that by then we have not only interventions to ameliorate some of the behavioral problems associated with autism, but really to change the overall trajectory of the disorder. There is a leap between Fragile X and autism for sure, but there's a lot of similarities, and as we learn more about the different types of autisms, if you will, I think that some of the clues are going to come from Fragile X, from Rett syndrome, and from other of these disorders. So with that hopeful note of where the future is going and of those game changers that we hope to see developed by young, bright minds like you, we'll finish off here.